Thank you. Thank you very much for the introduction, and thank you to the organizer for inviting me in this lovely place. I will discuss with you some of the techniques that we can use in the perioperative period, but also the anticipation of pain, and especially some of these techniques when there is still an open debate, and it will be a possible introduction for other talks in the afternoon and tomorrow. So a few words about the context, pain after joint surgery, but many things has been already said about that. The question is how we can anticipate, and if anticipated, can we apply some evidence-based strategies? And a few words about a possible aggressive neuropathic pain treatment as an answer to the unresolved question about postoperative pain and some perspectives. I'm sorry, yes. Okay. What about pain after surgery? One of the problems is that we can speak about perioperative pain, pain before, pain after the surgery, in the early days or in the weeks after surgery, but it covers different mechanisms, of course. And we know that in osteoarthritis and in postoperative pain, we have inflammatory processes, and it covers itself different mechanisms, but of course, we have an intense nauseous stimulation. It depends of the degree of tissue injury, and it can be modelized in animal models, for example, with the capsaicin model or with the Caragian injection. But after days of weeks, what happened in the patient in terms of chronicization of pain is often neuropathic, linked to nerve lesion, and it's modelized by fully different animal models. And so we have to see it as a global phenomenon in patient because the symptoms is pain, but these are completely different mechanisms, and so it's needed to have multimodal techniques to treat or to prevent it in patient. But it's very important to think about that. Of course, there is a common mechanism in all these pain symptoms is the central sensitization process. We have heard that from other speakers in this Congress, and the central sensitization is higher when the afferent input is intense, repetitive, before and of course after surgery, depending on interneuronal modulation, and of course modulated too by descending inhibitory pathways. And all these things, including the inflammation in the CNS, can be modulated by some drugs that we can use, but it's a so complex phenomenon and so well conserved on an evolutionary plan that we need, again, multimodal technique to hope to be able to influence as we can this type of pathophysiological processes. And supraspinally, of course, the influence of the psychological factors is very important, and the possible imbalance between vulnerability and resilience in our patient, the expectation of pain, the catastrophizing processes, that can influence negatively the pathophysiology of pain during and just after surgery, and possibly leading to chronic postoperative pain and not to pain resolution after surgery. And that can be seen in the pain trajectories that we can follow, as shown by Patricia Lavandome, showing that after knee surgery, some of the patients developing persistent post-surgical pain can have different pain scores just the day after surgery, but especially patients developing neuropathic pain after surgery have a completely different pain trajectories during the second half of the first postoperative week. And Dominic Fletcher in the pain out study have shown that, of course, the chronic preoperative pain is a risk factor for postoperative moderate to severe pain after surgery. Not necessarily the worst postoperative pain score, but it can depend of what we called exactly worst postoperative pain scores in mobilization or at rest. But percentage, interestingly, percentage of time in severe pain after surgery is an important risk factor for chronicization of pain after surgery, leading us to say that 1 hour in severe postoperative pain, so the day after surgery, can lead to an increased risk of 5 to 10% of chronicization of pain after surgery. So it's a very significant problem. So, defined as persisting at least 3 months after surgery, chronic pain can occur in approximately 20% of the patient. For example, it's only one example, 20% of the patient after knee surgery. And it's also present in most recent epidemiological studies, up to or even more 20% of the patient. And these patients, when we divide the patient with pain 1 year after surgery and without pain 1 year after surgery, we see that the pre-op pain score are different. Yes, it's not a huge difference, but it's different. So the pre-op pain score are different. We could eventually anticipate more pain after surgery when the patient suffer from a high pain before. But more importantly is the difference in terms of central sensitization and temporal stimulation. For example, here with repeated stimuli, pinprick here, the pre-surgery central sensitization assessment that we see here is still present 1 year after surgery. So it's important to recognize, but it's important to see that it's an ongoing process that eventually we could influence, but seemingly that we should better anticipate and eventually assess before surgery, for example, with quantitative sensory testing. And it can be dependent of preoperative pain, but it can be dependent of preoperative pain treatment too, and especially with opioids. In this graph, you see that it's not the pain by itself that seems linked to central sensitization here in terms of heat pain thresholds, but these are the patients in pain with opioids, in pain with pre-op opioids. And biologically, it's of course plausible because we know that opioids induce hyperalgesia, but it seems actually to be dose dependent. If we divide the patient between high and low pre-op opioid doses, we see that the maximal tolerated head temperature is clearly different between both groups. So patient with pain before surgery, but especially with opioids, is at higher risk of postoperative severe pain. And what are the possible evidence-based strategies that we could use in these high-risk patients? We will focus on level 1 and level 2 studies, so randomized controlled trials, but without forgetting that the risk factors, the psychological risk factors, are well known from years and years, from decades. Here, 50 years ago, in the New England Journal of Medicine, was clearly shown that encouragement and instruction of patients before surgery can induce a modulation of pain after surgery. So probably that we could reinvent the wheel in the following years by introducing the psychologist or some psychological programs, or to manage the expectation of the patients, or to assess the expectation of the patient before surgery, to have the right patient for the right surgery, but also at the right time. So for anxiety, not directly linked to catastrophizing, but also psychological factors, where we know that benzodiazepines are not anymore our first choice before surgery, is pregabalin an option? Clearly, it's a medication that can have an anxiolytic effect. There is a high level of evidence about that, and we use it in chronic pain management, and so it could have a place before surgery, especially because it reduces opioid consumption. It improves postoperative analgesia a little bit, not so much, but a little bit. And it reduces postoperative hyperalgesia. But it's important to know that pharmacokinetics are very important to know because the peak in the CSF occurs, in fact, more than 6 hours after the first administration. So when I use it, I give it to the patient at least the day before surgery, and not only just pre-op, just 2 hours pre-op. And the problem is that if you use it days before surgery, you can have, of course, side effects like drowsiness, and so it's not very practical to use it in all the patients. So the question remains open to which patient subgroups we should use, which patient would benefit the most of this type of medication, and at this time we don't know. Intraoperatively, now, what we could use, locoregional analgesia, like epidural, it could have a place to prevent chronic postoperative pain, but we have to recognize that it's not well shown in orthopedic surgery. It seems to be true after a thoracotomy, but we cannot use this type of techniques if the surgeon wants to mobilize early the patient, and it's true also for peripheral nerve blocks that in many teams has been replaced by local infiltration done by the surgeon. And so we have to tailor exactly the technique that we use to not be a problem for the postoperative early ambulation of the patients. Intraoperatively, we can use many other adjuvants, mainly clonidine, ketamine, IV lidocaine. The evidence is not so high that for the two foremost. The NSAIDs, I will not speak a lot about the two last NSAIDs. We know that a lot the problem of bleeding is not anymore a big problem if bleeding is well controlled by the surgeon, so it's mostly dependent on the surgical technique. Clonidine clearly lower the analgesic consumption. It's not a potent analgesic drug by itself, but it permits to reduce the analgesic consumption. And it's, for me, mainly a keystone of opioid-free anesthesia. And another one is ketamine. Ketamine is, in fact, one of the only drugs for which we have relatively clear evidence for a role in the prevention of chronic postoperative pain, but unfortunately not in orthopedic surgery, and the p-value is just 0.08 here, the orthopedic surgery. So probably that the mechanism of chronic postoperative pain are different in different patients, and depending on the population and the surgery in which we do a trial, we can have very different results, of course. And so it's important to interpret correctly the trials when we see that to have finally a right answer to, we hope, a good question. But even if we use these techniques, when we have anticipated that the patient is taking pre-op analgesics, eventually we have done regional anesthesia analgesia, we can see that some of the patients are in the post-anesthesia care unit with severe postoperative pain, and it can be dependent by the anesthetic techniques by itself, and especially the high intraoperative opioid dose. That is clearly a risk factor of moderate or severe pain, of worse pain after surgery. And only one example, an interesting experiment exposing healthy volunteers to capsaicin. And we know that capsaicin induces a burning pain, induce an overactivation of C fibers here in this model, 1 hour after the application, approximately 50% of overactivation of the C fibers. And we see that in the volunteers, when we stop the infusion of remifentanil, an opioid widely used in high doses by anesthesiologists, we see that after the withdrawing of remifentanil, we see a similar, approximately 50% of overactivation and central sensitization and overactivation of C fibers. And so the question is, do we have actually to expose our patient to this type of medication? Because it could be, or it may be, long-term side effects. I don't have data in orthopedic surgery, but after a sternotomy, it seems indeed that patients that have received the highest doses of remifentanil have an impressive odds ratio for development of chronic pain of more than 6, 1 year after surgery. So it may represent an important problem in terms of iatrogenicity of our techniques. Nevertheless, we can use opioid-free anesthesia, so no question about remifentanil or opioids, locoregional anesthesia, premedication with pregabalin, clonidine, administration of ketamine too. These are not patients undergoing orthopedic surgery. These are healthy volunteers undergoing a liver surgery for living donation for one of their children. So living liver donor. So no pre-op pain, but in some cases, some type of anticipation for severe pain. And I have seen all these healthy volunteers. These are not actually patients. I have seen, and with an informed consent, a good information, etc. And we see that even with all these techniques, the results are not so good. We can have severe pain after surgery. So the final answer is not obtained. It's still an not fully resolved issue. So one answer could be an aggressive neuropathic pain treatment. Maybe yes, because, for example, in the knee we could say that postoperative pain is always, at least partially, always neuropathic. 10 nerves innervate the joint. Invariably, there is a nerve lesion, a sensory loss, a suggestive second, surgical evidence. In fact, we can never exclude a deep neuropathic pain. Anti-neuropathic treatment like pregabalin are often useful. And so why not to use it in all the patients? Yes, but you remember these graphics about pain trajectories, but we see that here the maximal pain scores after surgery are not necessarily different between patient with or without neuropathic pain, even if this patient and this one have persisting post-surgical pain. And so probably that in some of the patients it could be true and in other not. Do we have to expose all these patients to anti-neuropathic drug? In fact, we don't know. And in terms of pain trajectories, if we see in another surgery, these are breast cancer surgeries, well known to induce postoperative neuropathic pain. But we see that when the pain scores are not so important, median of 4 after surgery, we see that the pain trajectory seems not to be different between patients with persisting pain 3 months after surgery compared with the patient without. And the pain trajectories by itself are not necessarily very useful to differentiate the patient that will develop or not persisting pain. So probably that it could be in some surgeries more or less specific, depending of the type of the patient and depending, of course, of the intervention that was done by the surgeon. And in fact, we could say no, pain is never neuropathic in this case. No biopsy is available. In fact, we will not have any of the important criteria that we need to confirm that the pain is neuropathic and the criteria that we need to do the diagnosis and to give medication for well-done diagnosis. No paraclinical confirmation. Knee arthroplasty is mostly not linked to chronic pain. Of course, patients are coming to the surgery often for pain, and surgery is a treatment for pain and not a cause. And so there could be a balance between yes or no, is it always or never, and probably sometimes we could use some questionnaire, diagnostic tools, like the DN4 questionnaire is the French-speaking one. It's a probabilistic tool that could help to diagnose the probability to have finally a neuropathic pain or not. But you know that the sensitivity and specificity is of course not 100%. And if we take a fictive patient series of 100 patients that could have or not a neuropathic pain and could have a positive DN4 questionnaire or a negative one, if the prevalence of neuropathic pain is 10%, because the prevalence of neuropathic pain can be 50% into the 20% persisting post-surgical pain, we see that the negative predictive value of the DN4 questionnaire in these settings is high. If the DN4 questionnaire is negative, the probability to have definitive evidence of neuropathic pain is very low, but the positive predictive value is very low too. More than the half of the patient will be a false positive diagnosis of neuropathic pain. So it's not an argument to not use questionnaire, and of course not to search neuropathic pain symptoms, but it's an argument to say that a definitive diagnosis of neuropathic pain or not, it's probably not a good issue if we want to follow populations, but more than probably we should note the neuropathic component of the pain. Are there some more or less neuropathic component in the persisting post-surgical pain, more than a black or white phenomenon? And it could help us if we design trials, not only to test in big phase 3 trials intervention in heterogeneous population, but it could help to design small randomized controlled trials in a design called the diabolo design by the oncologist. Diabolo design testing a specific intervention for specific pathophysiological mechanism and not for large heterogeneous patient series. And so firstly, we have to design trials to learn exactly what's happening to the patients, and trials to understand, and for example, which are the genetic factors or the psychological factors, and to design trials to test specifically some intervention to modulate specific mechanism. For this, we have to set up databases before and also after. We have to set up registries and to analyze it as in quality insurance program, like in post-commercialization phase 4 studies. And it will help us to understand better what we are doing to our patient and to try to improve it. For example, only one example showing that our patients are in fact very different and we are not recognizing it well. This is a series of 60 patients, and after surgery, the analgesic consumption is expressed as unitary dosage. So this is the analgesic consumption, and the SPS questionnaire is a questionnaire assessing the anticipation for pain, for postoperative pain, so partially linked to catastrophizing. And we see that in a mediation analysis, in a mathematical model, of course, the anticipation of pain is mediated by anxiety, here assessed by the HIDS questionnaire. But nearly all what's not mediated by anxiety can be modelized by a modulation, a negative modulation by an inflammatory parameters that it's present in all the blood tests that we have, the ratio, the neutrophil to lymphocyte ratio. It's a very simple inflammatory markers used by cardiologists or by oncologists. And so some of our patients have some type of immunocompetency, probably linked to some psychological factors or other than we don't know, but we have very heterogeneous population, and at this time we not recognize it sufficiently well. So to conclude, more than probably that the shift is ongoing to translational research, postoperative pain and its quantification to improve the perioperative management of pain. We have to design trial to understand complementary to lab research, to constitute registries, and to identify biomarkers, to design as well as we can clinical trials, and to improve therapeutic efficiency, effectiveness, to progress in the management of postoperative pain. Thank you very much.